Test. Hello. 1 2. 1 2. 1 2.
Yes.
Testing.
Go to the back. Don't make. All right, we are good to go. For those that are sitting way in the back, can you please move on up? Please move on up if you're sitting way in the back. I'll use my outside voice. All right, let's get to the front. All right, we're getting ready to start. Please find a seat. Yeah. So, a mic stand, really. A table mic stand, if they have one. But if not. So, ladies and gentlemen, our agenda for tonight, after the opening prayer and greetings from Ms. Gant and Mr. Owalewa, we're going to have an overview and timeline, which I will provide. And that overview and timeline is about why we are here and what has happened. I will not be sharing my own opinion. I will be reading from specific news reports about Cedar Hill Hospital. Then I will engage in conversation. After the overview and timeline, we will have a back history with invited guests and professionals that are seated here. After the back history, we will have community experiences. If there are any of you who have had a community experience with Cedar Hill. After community experiences, we will have a discussion, an open discussion about solutions, and then we will conclude. We have about a little bit more than 2 hours to have this program. For those that don't know, my name is Ambrose Lane Jr. I am the chair of the Health Alliance Network, which is DC's largest community-based health advocacy group in the District of Columbia. I'm sorry, thank you. Oh, yes, I will. I don't know if that's going to be. I'll move over. very good. Can you hear me? Okay. And I'm sorry I can't hold the mic with my right hand. I am recovering from a stroke that I had last March. To God be the glory. So how did we get here? How do we get to the point where we have to have a community forum about a brand new hospital that was promised to the black community and the people who live east of the river? Well, I'm going to take you through, starting with the statement that was made by our mayor, Muriel Bowser, and we will take you through a timeline through the resignation of the CEO, Tony Coleman, that occurred last month. But Cedar Hill Regional Medical Center, GW Health in Southeast DC, a $434 million, remember that number, a $434 million facility opened in April 2025, has faced intense instability due to severe understaffing, a high volume of low acuity ER visits, and financial strain, leading to the CEO's resignation and ambulance diversions within its first 45 days. Key aspects of the instability: staffing and leadership crisis. The hospital, operated by Universal Health Services and staffed by medical faculty associates, or MFA, physicians, has struggled with significant staff shortages, including over 60 open positions for nurses and managers. The CEO resigned in January 2026, less than a year after opening. Operational strain. The emergency department was overwhelmed with reports of up to 80% of patients seeking care that could have been treated at an urgent care center. The facility had to close its doors to ambulances 5 times within its first 45 days. Financial and safety concerns. The affiliated physician group, MFA, has faced financial instability, losing over $450 million. Remember, I told you to remember that $434 million, the cost that it took to even build the hospital? Well, the $400 million is actually higher. It is at this point close to $450 million that MFA has lost. Additionally, it has been reported on patient care violations and a lack of promised services such as specialized outpatient procedures. Underutilized capacity. Despite the high ER demand, the hospital was unable to open all planned inpatient beds due to nursing shortages, with only 32 of 80 beds open in early July 2025. The facility was designed to address health disparities in Ward 7 and 8, but has struggled to gain community trust due to these operational challenges. Medical Faculty Associates, MFA, is a 501c3 corporation formed in February 2000 to operate exclusively for the benefit of the university in providing clinical, teaching, and research services. Clinical services include professional, physician, and related healthcare services to patients in the greater Washington, D.C. community. MFA maintains accounts and prepares standalone financial statements in conformity with GAAP applicable to not-for-profit healthcare entities. MFA Physicians Insurance Company is a wholly owned subsidiary of MFA and provides professional liability insurance for MFA and its employed physicians and providers. Remember that. That's a very, very important point. They have a wholly owned subsidiary which provides malpractice insurance for all of its physicians. Now let's begin. I haven't even started. Reading first the mayor's statement on February 6th, 2025, Washington, D.C. Today, Mayor Muriel Bowser announced the new Cedar Hill Regional Medical Center on the St. E's East Campus that will officially open on April 15th, 2025. The delivery of the new hospital is part of the district's partnership with Universal Health Services to create a comprehensive and integrated system of care for communities east of the river and all DC residents. The mayor announced the opening date at a celebration of the renaming of the entertainment and sports arena to Care First Arena. Quote, Cedar Hill Regional Medical Center represents my promise kept to Ward 8 and to all DC residents. The new hospital and the system of care it is part of are all part of one shared goal, improving health outcomes for DC residents. This $434 million project includes a state-of-the-art 136 bed, but expandable to 184 beds, full service hospital with maternal health and delivery, including a level 2 NICU. Does everybody know what a NICU is? That is where the babies are kept, just so that you know. A trauma center, ambulatory pavilion for physician offices, clinics, a 500-car parking garage, and a helipad for emergency transports. Let me just say this. The Health Alliance Network back in 2020, 2019, 2018, 2017, we went around Ward 7 and Ward 8 to all the ANCs, and we had most of them pass a resolution demanding what the people wanted at that hospital. One of the things that we demanded was a helipad. Why did we demand a helipad? Because Ward 7 and Ward 8 have many at-risk births. And if there was an at-risk pregnancy where the mother needed to be taken, or the would-be mother needed to be taken to another hospital, you needed a transport vehicle, which was a helipad. You could not wait for an ambulance to travel halfway across the city. I'm sorry that I segued, but I got to deal with that. Cedar Hill Regional Medical Center is part of an integrated delivery network of care that includes the George Washington University Hospital, Cedar Hill Urgent Care GW in Ward 8, and the Fletcher Johnson freestanding emergency department scheduled to open in 2027 in Ward 7. I'm a Ward 7 resident. I found out this week that the Fletcher Johnson freestanding emergency room will not open in 2027. It has been delayed. This integration will ensure healthcare equity for residents of Ward 7 and Ward 8, providing access to higher quality care in their own neighborhoods and communities. In addition, the district's second advanced, now listen to this. In addition, The district's second advanced technical center is set to open in the 2025-2026 school year, which is now, at the Max Robinson Center, where high school students can study to prepare for careers in healthcare, building a pipeline of skilled professionals for facilities like Cedar Hill Regional Medical Center, GW Health. That was the mayor's statement last February. We know for a fact that that is not happening. Second article. MFA hires new physicians for Cedar Hill amid staffing concerns. This was in March 3rd. So the mayor had made a statement in February, and as of March 3rd, they were trying to hire. Cedar Hill Regional Medical Center, a $434 million facility, set to be staffed by MFA physicians and operated by Universal Health Services, the owner of GW Hospital, will open April 15th as part of Mayor Muriel Bowser's plan to combat health disparities in Wards 7 and 8. MFA officials said they are working to hire new physicians to staff the hospital after DC council members expressed worries that the MFA will be unable to meet the hospital's staffing obligations since the enterprise requested late last year to renegotiate its contract due to its financial challenges. City officials chose UHS to own and operate Cedar Hill in 2020, including staffing the facility with physicians from MFA, a group of physicians and faculty from the School of Medicine. In the original agreement, MFA pledged to staff the hospital with 160 physicians, the Washington Post reported. Sometime around December 2024, the MFA requested that UHS renegotiate its contract due to financial challenges. The practice has lost $107 million in the last fiscal year. Let me make sure that's clear. And that was written in March of last year. To date, they have lost almost $450 million. Next article. A new DC hospital grapples with too many patients and too few nurses. As soon as DC's newest hospital opened its doors in April, the emergency room was overwhelmed with too many patients and not enough staff. Nurses were pulled from other departments. The top nursing administrator clacked downstairs in heels to treat patients herself. The chief operating officer cleaned beds. In the first 45 days, about 5,300 people came into the ER for treatment. About 80% of those people could have been treated at an urgent care, which is nearly double the district-wide average rate of low acuity or non-emergency patients in the ER, officials say. Federal law bars hospitals from turning anyone away, and the most serious cases are treated first. Others wait. One woman came in for a non-urgent STI exam and waited 5 hours. Nobody wants to wait for 5 hours, the CEO said. I don't like waiting. But when you come in on a Friday night in Southeast Washington, when you've got a lot of stuff going on and you're here for an STI exam, you're going to wait. At the same time, the hospital could not hire enough nurses to staff as many inpatient beds as they planned. Of the 80 total inpatient beds, only 32 were open as of July 1. Now, I just read an article from March, this is now July 1, which is 16 fewer than expected. The conditions also prompted Cedar Hill to close its doors to ambulances 5 times between mid-April and the end of June, according to a spokesman for the DC Health Department. From a report from Cedar Hill, this is from a Cedar Hill's own report. This was the Cedar Hill Regional Community Impact Report that was written and published last summer. In our first 40, it's called A Snapshot of Care Delivered. In our first 45 days, our emergency department saw a remarkable 5,323 patient visits, including 4,006 adult and 1,317 pediatric visits. That's more than double the average daily ED volume previously seen at United Medical Center. While our ED team, check this out, while our ED team rose to meet this demand, our data revealed a concerning reality that 80% of these visits could have been treated in a primary care or urgent care setting. Let me repeat that, because you've heard me say that before from the other reports. 80% of these cases, these visits, could have been treated in a primary care or urgent care setting. We're going to talk about why they couldn't be treated in a primary care setting. I've already said they could have been treated in an urgent care setting, but there's another reason why they couldn't be treated in a primary care setting. This reinforces the urgent need for expanded access to preventative and routine care, access that is, quote unquote, on the way based on their report. Okay? Next article. This was November 19th, 2025. The article is entitled, DC's new hospital still isn't fully open months after patients first arrived. This is now November. The new Cedar Hill Regional Medical Center, GW Health, has not yet delivered services key to keeping it financially afloat. When DC spent more than $400 million to build its newest hospital, residents were promised prenatal care, outpatient dialysis, family medicine would start shortly after the ribbon cutting in the spring. A July deadline came and went, forcing residents to continue to trek across the district for care. Let me say that again. A July deadline came and went, forcing residents to continue to trek across the district for care and leaving part of the 400,000 square foot facility dark. Now, the director of nursing, by the time of this report, had resigned. The COO, the chief operating officer, by the time of this report, had resigned. As a matter of fact, he resigned last spring. She resigned during the summer. Continuing on. Now, 6 months later, hospital officials say they're finally closer to adding more services by the end of the year. Although the emergency room was booming on day one and inpatient admissions have steadily increased, outpatient care, the appointments and elective procedures that help keep a hospital financially afloat, have not yet materialized. This is now November. But the hospital recently unveiled a rough timeline for adding services, and this you need to hear. Family medicine, obstetrics, and post-operative care next month, that is December of last year, followed by general surgery in January, that was last month. Then gastroenterology and orthopedics in February, that's this month. And neurology in March. Everything else, such as cancer care, cardiology, and nephrology, will be in April. The timeline was laid out in a letter from Jason Barrett, Chief Executive of GW Hospital, Bill Elliott, Chief Executive of the Doctors Group, MFA, and Ellen Granberg, President of George Washington University. Now, on January 16th, and this is one of I have two more reports. The CEO of DC's newest hospital resigns less than a year after it opened. So after all that, the CEO, Tony Coleman, resigned last month. Anthony Coleman's departure will mark the latest turnover of management at Cedar Hill Regional Medical Center in Southeast. The chief executive of DC's newest hospital is stepping down less than a year after Cedar Hill opened in Southeast Washington, a hospital spokeswoman said Thursday evening. Anthony Coleman's resignation is effective March the 13th, the hospital said. Kimberly Daniels, Chief Operating Officer at George Washington University Hospital, will serve as interim Chief Executive of Cedar Hill starting on January 26. With Coleman's departure, the first senior leadership team at Cedar Hill, including the Chief Operating Officer and the Chief Nursing Officer, has turned over and left. Universal Health Services, the parent company of George Washington University in Foggy Bottom, which the city tapped to operate Cedar Hill for 75 years, hired Coleman in November of 23 to shepherd preparations and hiring for the new hospital which opened. But the GW Hatchet, and for those that are following this, the GW Hatchet is an independent student newspaper at GW. As a matter of fact, because they don't get their money from GW University, they can say anything they want. And in fact, GW Hospital doesn't like the GW Hatchet because they tell the truth. This is a fact. This is from the Hatchet. The resignation comes in wake of staffing concerns about the $434 million hospital, which district officials broke ground on in 2022 and opened in April. As Coleman told the Washington Post earlier this year, that a shortage of nurses led to the hospital becoming overwhelmed by patients. The hospital currently has 63 open positions, including director of nursing. This is in January. They just hired someone to become the director of nursing. I mean, like within the last 2 weeks. And that's because they knew we were having this forum. 63 open positions, including director of nursing, manager of trauma services, and over 20 nurses. The hospital also had yet to follow through on promised services like outpatient procedures as of November. Remember the list of services that I said they would have each month? Those haven't happened. Local leaders, that's us, raised concerns about the staffing the hospital prior to its opening due to the financial turmoil of medical faculty associates, a network of physicians who teach at the School of Medicine and service medical centers that has lost over $444 million, more than the cost of the hospital. In November, GW officials announced UHS would establish, this is also important, GW officials announced UHS, Universal Health Services, would establish a new nonprofit to take the place of MFA, to directly hire MFA employees to staff both GW Hospital and Cedar Hill if ongoing negotiations to end the university's financial support for the medical enterprise succeeded. And that, ladies and gentlemen, is the history over the last several years of the plight of Cedar Hill Hospital with George Washington University. Now, there are some issues that I'm going to raise before I bring up Dr. Chapman and Dr. Marilyn Corder. You will also hear from Kate Wana Williams and Shanita. Shanita is a nurse?
Nope, respiratory.
Respiratory therapy, okay.
Business owner.
So we are studying whether or not GW, through MFA and through UHS, has broken its contract with the city. We're looking into it. And if they have, they're going to have to pay. We're also looking into who else is culpable. City leaders, including the city officials who pushed for the signing of the contract with UHS and with MFA, had to know that MFA was losing money when they signed the contract. So if they knew that they were losing money, they also had to know that there was a real possibility that MFA would not be able to fulfill its obligation of staffing the hospital. And you see from the news reports that I read, they couldn't staff the hospital. Now, MFA, so that you know, MFA was responsible for staffing the physicians at the hospital. But UHS was responsible for staffing the nurses and other personnel. GW, UHS, and MFA refused to develop relationships with Trinity University. Why Trinity? Because Trinity University supplies nurses. They graduate nurses. The University of the District of Columbia graduates nurses. Howard University and HBCU, like Morehouse and like Meharry, graduates black doctors. Okay? Now, how does this relate? UHS controls MFA. UHS chooses the chairs of the individual departments. So Department of Nephrology, other departments at the hospital, gastroenterology. GW or UHS chooses who the chairs of those departments are. The chairs of the departments choose the doctors. So if you wanted a hospital that was a community hospital that had black doctors that already were taking care of Ward 7 and Ward 8 patients, why were they not included as part of the Cedar Hill experiment? Why did they create barriers to hire the community doctors and the nurses to be able to take care of patients? Now, I've been told directly from someone at UHS or from GW that UHS has what is called an algorithm, an AI algorithm. That AI algorithm is used to determine nursing staffing at the hospital. That's what they do. Why is that significant? Because Ward 7 and Ward 8, because of a long history of negligence, are sicker communities. That's why there's such a gap in life expectancy. They're sicker communities, which means that they require more personnel, in particular nurses. So if their algorithm says that there are 50 patients, and those 50 patients only need 3 nurses, that's based on a model that does not include African American communities. That's why that is significant. Because their algorithm is a racist algorithm. The algorithm AI itself is not racist, but whoever programmed it had racial bias. Because black communities, by virtue of the fact that they have been neglected, need higher levels of care. Now we're going to go into some back history, and I want to introduce, I'm going to go ladies first if that's okay. I'm going to let Dr. Corder. Dr. Corder was the former chief of staff at United Medical Center. And then we'll have Dr. Chapman, and then we'll have Kwana, who did a fabulous report on GW and on Cedar Hill Hospital, and then we will follow with Shanita. Okay. Dr. Porter.
Good evening. Can everyone hear me? Yes.
Is your mic on?
I don't know. Is it on? Okay. My name is Dr. Marilyn McPherson Corder. I was born right here in Ward 8. I grew up in Parklands. Anybody know where that is? I started at Garfield Elementary School, and then just up the street, Morris Road, Our Lady of Perpetual Help. I'm a physician. I trained proudly at Howard University College of Medicine. Then I did residency at Howard University Pediatric Department, and I did 2 specialties after that, genetics and adolescent medicine. And it's really not about me when I say that, but I want to make sure that we understand what was UMC, and when I grew up it was K-Fritz, and then it was Greater Southeast where I also trained, and now UMC is gone. I was called to come on staff at Greater Southeast by the CEO because at that time, GW doctors were walking out of the nursery. Yes, they just left the nursery. They announced, they said, I'm leaving, we're leaving. And they needed somebody who had the commitment to the community. So they called me. I came over, Dr. Allen said, this is you. You got some folks on bench, you have some folks under phototherapy, you have this, it's me. We don't have residents or medical students. It was me and one neonatologist. And then later, Dr. Fred Porter joined us. So every night, every day, I did the night shift, Dr. Selassie did the day shift, etc. We did that for 15 years. No residents, no medical students. We covered every weekend, every Mother's Day. My daughter said, you must be going back to residency. But the commitment was there. We had to do it. Now, we were told years later by the health officer, Dr. Nesbitt, that the people don't deliver there. Maybe you get 40 or 50 deliveries per month, so they vote with their feet. Well, let me tell you about the feet. Every day we had something called check-in call, meaning a mother would come in pregnant and maybe her boyfriend kicked her in her belly. Maybe she fell down, maybe she took some drugs, maybe she can't feel the baby. So we would stabilize using the sonogram, the lab, the doctors, the nurses, and every day we had 20 to 30 women called check-in call. We didn't get any credit for that. These women now, they can't even find a place to go for check-in call. So we did that, and we got them so stable that they then went to their designated place, be it Providence, be it Howard, be it GW. But saving those babies in utero is what we did, and a fine job of it. We had 5 OBs, Dr. Sylvester, thank you. Dr. Sylvester Booker is one, Dr. Stevie Proctor, who also grew up here in Southeast with me. We saved the babies, we got them stable. And I'm not even trying to say we were the perfect, no, we had our issues. And we fought and fought for the council to give us more money, because what they did, they continued to drain us down. I was down at the council begging and aggressively talking to the council, and told them they were cutting us by 7 million, not 400 million, 7 million. We had a 20 million budget that went from, or 27 million to 20. We were bringing our own Band-Aids, our own tourniquets. That hospital, we kept that hospital doors open by just our commitment. And finally, they gave us that other 7 million because I reversed the vote from 9 to 2 to 2 to 9. But it's like after a while, we saw what was happening. They were just draining us. So as chief of staff, over 300 doctors, we committed and we said, okay, at least they're saying that we could be coming to the new hospital. That was once the promise. Part of that hospital is a professional office building. That means there were 20+ doctors having their private practice for decades. I've been in practice 40 years. For decades. They were seeing patients, generations, grandparents, parents, children, and children. For years. At the last minute, they were told, you're not invited to the party. They shut down the professional office building that's always connected to a hospital, and those doctors had to leave. Do you know how hard it is to establish a private practice? Very difficult. So when they left, the patients scattered. That's why you had all those patients going to the ER. The doctors weren't there. The doctor's not there. So unfortunately, it made the worst case scenario for Ward 7 and 8. All these promises are not kept. We have a good 25 community doctors who said, we'll come back. We'll come. It's not about the money, because they hardly pay you, but it's about the commitment. So now we're in talks and negotiations or what have you to come. But it was told recently that only 3 or 4 doctors put in their credentials. Now listen to this. There are more doctors that have, but they're blockage, because they have to go through UHS, GW, okay? Now we're talking some politics now. And some doctors are like, I don't want to jump into that fire. My license would be on the line. You know, we need to have some more leadership from the community doctors, so we can look at what's going on in ER, so we can look at what's going on in the surgical suite, so we can understand. Because not having a say, and you put your license there, you're gonna go down with it. $400 and some million in debt, my God. And all I'm saying, as a physician here, 3 generations Washingtonian, Southeast grew up, I'm saying Howard trained that we need to be able to have some leadership. They're offering us a few seats at the table, but it's not anywhere near leadership or voting power.
That's right.
And it's so important that we have that. United Medical Center, my daughter went there to get stitches. My mother was there, my aunt was there, because I trusted the nurses and the doctors. We came in, we were committed, we rolled up our sleeves and we did it. And all I'm saying is now the community needs to speak up and say, not only let us few in, but allow us to partner, to have some leadership, to have some voice, so that we can take care of the community that the city turned their back on. All of these promises, I'll tell you, I've heard them all. It's very disheartening. It's frustrating. I'm upset. I'm angry. I'm still practicing. I should have retired, but I will take this through. I will continue to practice to make sure that we get it right by the residents in Ward 7 and in Ward 8. So in closing, I represent doctors of color. I'm part of the NMA, National Medical Association. We have our president here, Dr. Roger Mitchell. And I just want, this is 2026, and we have people coming in waiting 12 and 14 hours, and we have horror stories. I'm not going to talk about those, but you all know and have heard. And what we need to do is come together and take care of our patients in a professional, in a caring, in a culturally sensitive manner, and not just throw them away. We are just, our lives here, Ward 7 and 8 lives, are just as valuable as Ward 3, 4. I have a practice up in Northwest. My patients followed me. Okay, my patients followed me, because what I ended up doing right after the babies were born, I saw them 2 days later. I saw them a week later, way before they had insurance cards, to make sure that those babies were alive, to make sure even if WIC didn't come in, that they weren't extra diluting the formula until they get 30 days on their card. We just did it. We gave them formula, et cetera, because that's what we learned at Howard. That's what I learned as a DC resident, as a physician. So I'm gonna stop, and all I can say is stay tuned and follow this guy, Ambrose. Ambrose remembers when we fought tooth and nail for money.
That's right.
10 years ago.
That's right.
And we fought and fought and fought, and we will continue to fight. Thank you.
Dr. Edwin Chapman.
Hi, I'm Dr. Edwin Chapman. I'm also a member of the National Medical Association. And I'd like Dr. Mitchell to stand up. Dr. Mitchell, as you know, was the chief medical examiner for 7 years in the District of Columbia. He subsequently went back to Howard University as the chair of pathology. He was then president of Howard University Hospital, and now he's the president of the largest African-American international organization for African-American doctors. So that's how important this is. So I won't steal his thunder, but I will point out his theme, which is the new Reconstruction. And the reason that he picked that theme is because he understood the environment that we're in. We're in a very tough situation because as the country becomes blacker and browner and corporations take over healthcare, they see us as a commodity, meaning that they can underserve, and that's what we're seeing right now here in the nation's capital with 3 medical schools. When I graduated from Howard University Medical School in '73, we trained, both of us trained at the old DC General Hospital. So if you could imagine, you had 3 medical schools with students, interns, residents, and paid government staff taking care of this same population. Actually, it was even more. It was about 200,000 people instead of just 150,000 that we're talking about east of the river. So when you talk about volume and personnel, you're really talking about the fact that you need all of these entities involved. What was not mentioned was when the contract was being negotiated 7 or 8 years ago, they purposely excluded Howard University faculty and students. And I can give you the newspaper articles. So when I testified in 2020 on June 30th, I said 70 years from now, nobody would believe that we could not take care of ourselves and that we would build a hospital and exclude Howard University faculty and students, exclude black physicians. So you're seeing, when we met with the CEO of Cedar Hill, there were 15 physicians in the room, accounting for at least 100,000 years of service in this community. So I've been on Benning Road for 46 years, and I too refuse to retire until we get this straight. But the issue is we have to take care of our own communities. We have to be responsible for our communities. And that means that we also have to include what we call the social determinants of health. 80% of health outcomes are related to things that happen not in the doctor's office, not in the hospital, but once you're discharged back into the community. If you don't have a job, if you don't have housing, if you don't have food and other services, then what happens in the physician's office costs more. You come back sicker, and that's what we're actually seeing. So when you look at the business model, and I just can't believe that these so-called smart people in the government and university put this together and excluded over 20 physicians of all specialties in the community, and then didn't expect to see the emergency room overflowing with patients with things that could have been taken care of in a primary care setting. The district has 300,000 people on Medicare and Medicaid. That's almost, well, that's about 40%. They have a $3.5 to $5 billion budget for Medicaid, which means that much of that money is being wasted in tertiary care and other issues that could have been taken care of at a much lower cost. So what we're saying is that the solution, and we're going to talk about solutions, would include bringing primary care. You have to have primary care private practices in addition to clinics. Everybody doesn't want to go to a clinic. I've had patients, the same patients, for 20, 30 years. So patients build a trust, and the reason why we set up practice in the community is because of that trust factor. If patients don't trust you, they're not going to come, and they're not going to come back. So part of that model is the trust factor. The other part, of course, is the social determinants of health, and the other third component is education. We need to continue the pipeline that Ambrose has talked about in order to supplement our community, rather than having outsiders come in and tell us that you don't qualify. I just got dropped by one of the 3 Medicaid managed care companies, and I had the largest portion of opioid use disorder patients in the city, and I took care of 90% of their patients, and they dropped me because I complained about the quality of the medication that they were getting. So these are the kind of things that we have to deal with, and I'm going to stop there.
So let me, before we go to our next 2 guests, there's some things that I want to share that have been mentioned. We mentioned primary care and the need for people to see their primary care doctor. Sibley Hospital, Washington Hospital Center, MedStar, before Providence closed, Providence Hospital, even United Medical Center, all of them have physicians' office buildings, and Howard, right on campus. What does that mean? That means that patients, instead of getting things that are medical issues that are easily addressed at a primary care doctor, they instead go to the emergency room. That was happening long before the advent of Cedar Hill. But it was exacerbated by the lack of planning by this city to put a physician's office building on the campus of St. E's, which has at least 3 or 4 buildings that are shells that have nothing in them, that they could have spent some money and created a physician's office building. Now, many of the community doctors that might have wanted to work at Cedar Hill had to get their credentials through UHS. In getting those credentials to work at Cedar Hill, they would have had to pay for their own office space. They would have had to pay for their own medical insurance. What does that mean? Most physicians, in setting up their own practice, and Dr. Chapman will attest to this, cost between $250,000 and $500,000. if you have graduating doctors from Howard University that have no clients, they don't have $250,000 to $500,000 to set up a practice. So here is where the council can make a difference. Well, I shouldn't get to this because we're getting towards solutions, but the council can play a role in mitigating those costs through legislation. I'll stop there because we are going to hear from our two other guests, and then we're going to hear from you. Is there anyone here who had an experience at Cedar Hill? If you have, raise your hand. And if you have not, then we're going to go straight to solutions.
Good evening, everyone. I'm happy to be here. I am Dr. Kawana Jeffer Williams. I'm a PhD. I'm an APRN, an advanced practice registered nurse and nurse practitioner. And my specialty is to ensure that patients are aware of their patient rights, and I am a health psychologist, and I am a compliance expert. So why would I be here speaking on Cedar Hill? I will tell you now, Cedar Hill, like many new hospitals, are ran by those whom put the wrong people in places that require experts. I am a health commissioner. My goal is to process big data, synthesize it, and deliver that data to policymakers on the Hill. The legal and political fraud that I investigate in clinical research is why I'm a clinical research nurse specialist from the National Institute of Health. My undergraduate journey led me to National Institute of Health, the U.S. Health Department, the U.S. Health and Human Services Department as a specialty officer at HHS. The research that Mr. Ambrose is speaking on came from my PhD research on health systems and how health systems are modeled in many different ways. And that model does not always fit the needs of the community. So, with my research on the health system of Cedar Hill, what I found was that there were many pending arbitrations. For example, the staffing issue, we can go back to the staffing issue. As a registered nurse, as a nurse practitioner, staffing issues start with the quality of care that's delivered by nurses. Do you agree? Okay. This arbitration that we found involved many fractions, forced notices, and several different severe actions and disputes surrounding the union. And I don't know if any of you, like myself, I support the union, especially as a health commissioner. The nursing department is the biggest department that costs hospitals the most money. Nurses themselves in-hospital care require nurses to work alongside MDs. Do you agree? The MFA was charged with hiring those medical doctors. The union is charged on retention and recruitment, but yet those nurses were still understaffed. The patient population that you're serving is high acuity, but the compliance measures is where quality of care comes in place. I will tell you, I'm gonna read some of my notes here. The failures of Cedar Hill came from putting the wrong people in the right places for the right people. For example, we are not delivering the care that is needed for oversight. When you remove the federal oversight out of community services, you lack quality care in primary care. You forget to put the structures in, such as the health systems, the health partnerships, and that goes to the health providers, which is the community health doctors. Once you remove the federal oversight out of our health care, you remove Joint Commission, which is why you're hearing a lot of these complaints. You remove Joint Commission, you get long ER waits, because those are our benchmarks. Joint Commission keeps nurses accountable. Nurses drive healthcare systems because they are the biggest healthcare department within the hospitals. They cost the most, but yet Cedar testifies that they are failing financially, but yet they are understaffed. These statistics do not add up for a healthcare law and legal expert such as myself. And so I'm wondering, if we truly have a hospital that's fully functional and integrative, but yet the healthcare system model that you're using is inefficient and ineffective because your nursing staff is also inefficient and ill-effective. So I want you to notice that I'm tying this back to how the nursing department drives the quality of care and the efficiency of the patient outcomes. Okay. Now, we use words like integrative care for Cedar Hill. Integrated care in Cedar Hill cannot be delivered by any other department other than the nursing department. And that is by law. Without an adequate nursing department, the nursing, going from nursing to medicine, requires a human response, requires social determinants of health to be addressed, and the environment. And that doesn't only include shiny floors, which is the pastor. It also includes how well the patient is interacting with the nursing staff and the medical staff of all types. This ties me back to what Cedar Hill also failed to do, accreditation. I said it. Oh, yeah. The accreditation that Cedar Hill failed to implement, one, nursing are our partners, not our labor staff. The union itself is here to support nurses in their practice, their full autonomy, meaning they are able to make sound clinical judgments, and the financial cost and burden should be in a partnership, a contractual, and this is by law, as a healthcare law ethics expert from Texas A&M Law School, and also a business research in healthcare from Howard University. I am going to give you my expertise stamped. The failures come from the lack of partnerships with the nursing department and providing nurses as a partner and not the labor and staff. Nurses deserve contracts that are sound and just as cost-driving as the medical doctors. Without the proper nursing department in place. This is why the CNO failed. I have never been a CNO. I've been offered twice to become a CNO. I have not done it because I really love healthcare law. But the CNO herself has stepped down twice. Because they are, I'm going to say it, incompetent. Nursing require highly skilled, highly competent, registered nurses with advanced degrees. I've had some bachelor's degrees now that can run some circles around you. Bachelor's degree level nurses that can run circles around you, but that comes with experience. They are hiring ill-experienced nurses. And this is where the failures are in compliance. When we remove the federal compliance, when we remove federal government, health administration resource services such as HARSA, I am a health administration and resources service registered nurse. I served in the Army as a ROTC Corps nurse in the HSRA, and thank you. And we build health systems. We come highly skilled, highly qualified, and the accreditations are based off of your nursing department. And because Cedar Hill does not have an adequate nursing department, they have failed you.
So that's very important because, as I said earlier, none of the players, even the city, they never even had discussions with Trinity, and they never had discussions with UDC. In addition to that, the doctors that are there, and let me say the way that they set this up. So, as I mentioned, you have chairs of departments. Those chairs do not reside in Cedar Hill. They reside at GW. They don't come over to Cedar Hill. Those chairs choose the doctors. But the doctors use what are called PAs, physician's assistants. So the physician's assistants do the bulk of the work. The doctors that are there, they might consult with them, but the patients, they see more physician's assistants than they see doctors. That is also a real problem, okay, because the doctors are not on hand to be able to really provide oversight in terms of patient care.
Hello, everybody. My name is Shanita Blakely. I'm a respiratory care practitioner here in Washington, D.C. I have been, I'm from South Carolina, but I've been here 23 years. I am also a business owner. I'm a Ward 8-based business owner. I serviced United Medical Center for 4 years. So I can attest to what Doc was talking about here. We, because I am a business and I was a contractor, there would be times when there were things that weren't available, and then we just, we got a Medline. I just went ahead and got a Medline account, and we just took care of those things. It's not reimbursable. I'd also like to point out that respiratory care services in DC are not reimbursable by Medicaid and Medicare here in the district. We have over 127 patients in the district on vents, with either tracheostomies or vents at home. One of the things that NTI Medical does is that we provide cradle-to-grave service. So we provide the actual person. I don't provide equipment unless you just don't have things, and then, then we do what we have to do. But we, for example, we take care of, when it comes to babies, we go to C-sections to support the infant after birth. We have a lot of mothers. One of the areas that we specialize in right now is we have a lot of mothers on antidepressants. And so when their babies are born, I'm sure Doc can attest to this, when their babies are born, they have a depressed respiratory, they're respiratory depressed. And so we usually use a CPAP, apnea monitors, things like that. Those things are very intensive when you're dealing with primarily premature babies, because we have a lot of that on this side of the river. We have a lot more preemies over here, so you'll see one of us a lot more. We also provide pediatric care. We have a lot of infants, well, not infants, but young people age 10 and under who are trached. Some of them have ventilators. They do go to school. We encourage them to go to school because they are a part of our community as well. They just have different challenges. We also take care of end-of-life care. So when it's time for, to wean off the ventilator and allow natural death, as they would call it, we also do that. We do a lot in the district. We don't advertise. You may not have heard of us. I don't put up billboards because I'm busy. I've been offering this service since like 2010. So I've been very blessed that people just kind of find me and call me and so on and so forth. I've also worked at every hospital in this district, every single one, every single one. I had some wonderful mentors at those hospitals that told me to quit and go start this business, so that's what I did. A lot of those people have passed away now, but super awesome. I still work with Dr. Daniel from United Medical Center, but what she's saying is correct. None of those physicians were offered positions. The respiratory care practitioners that were servicing UMC before were working under conditions that were not even close to ideal. I offered to buy an EKG machine, and I don't know why. I testified before the council. I gave ideas because I am a clinician, but I'm a business owner. So I'm about, making that check. So what pays a hospital is outpatient services, period. UMC had, I think 2 open MRIs. They had 4 hyperbaric chambers. Hyperbarics is good money. Like, man, let me tell you, you get a fire, but anyway, it's good money, okay? I suggested opening those things up, advertising, bringing those over to the new hospital, which they did not. I think they only have one hyperbaric chamber over there. I don't even know if they have one. And I don't even know if they have anybody to, because respiratory runs those. 0, they don't have any. Okay, so we used to have 4. That was the way to make the hospital profitable. And they did not do those things. I was integral when it came to adding Children's Hospital, the ER over there. We testified for that kind of stuff. So I'm moving and shaking in the community, but I spend a lot of my time in the streets because we are the link for respiratory between the hospital service, long-term care, which would be like rehab, formerly, what is this over here, Hadley? It's not Hadley anymore. What is it? Bridgepoint, right? Formerly known as Hadley, now known as National Harbor, which is not close to National Harbor. But anyway, something that I've noticed is that every time we have this, every single one of these hospitals are run by people who aren't from here. And I'm not from here, but I gave birth to a Washingtonian, so that should count. Like, I should get some of that, and I've been here a long time. But I have not met one admin, and I don't know, you guys correct me, I have not met one admin, I have not met one CEO that is actually from here. Have you?
Nope.
Okay, so it is like, for instance, Georgetown, I watched them go and recruit department heads from other states on purpose. Yeah, exactly. I watched every time a nursing director left, manager left, every time, they would never hire somebody from within to fix the little things because we understand what's needed. I live right here on Brothers Place, I applied to Cedar Hill. Just to try. I just was like, I don't need no job. Let's just try it out. They haven't called me back.
That's right.
I know I don't supply nurses, but I know several of them because, like I said, I'm in people's houses. I'm everywhere. So and there's 27 of us on staff, so it's not just me. There's 27 of us. But I know nurses that have applied that have not been heard back from. I know rad techs, because x-ray was a problem. So I don't get too much into the nursing weeds, but I do a lot of allied health service. So I do respiratory, rad techs, PCAs, which would be like CNAs, GNAs, sonogram, ultrasound. I don't know how they delivering babies with no ultrasound tech. Right. So I offered staffing services because we are a staffing company, just so you know. So that is what we do primarily. And then as a community member, I just kind of started opening up different services, like based on what we learned was needed. So like the home care thing, I didn't start out with that, but folks was getting discharged and didn't have nobody to take care of them. So we took all those on. I do hope that we come up with some awesome solutions. I think that we definitely could use a community member on the board, a clinical one, right? A clinical one as well as a non-clinical community member on the board, just because we do have to take into account reimbursement. Certain things pay certain amounts, and we have to know those things. And sometimes everybody doesn't know that, as well as a clinician person being on the board, because they will look at these numbers, these staffing to patient ratio numbers, and determine like, okay, well, you got this, you got 3 vents, 2 G tubes, a hip replacement, a knee replacement, and a broken ankle, and the ER is full. They look at that and determine, okay, so we got this right here. Oh, these 3-5 patients, okay, they only need like a half a nurse. That nurse can cover
right.
those 5 in another room. So we need somebody that's clinical that can say, hey, no, like 12 ventilators is too many for a respiratory therapist. Respiratory, you should have more than 3 in the whole hospital, because that's a lot to cover for one person. To cover 4 floors is a lot. One nurse should not have 20 patients in clinical or even long-term care. You should not have that many. There are things you need to know about your legislators. You need to make sure that staffing levels are something that you all are very vocal about, because I know you get tired of going to places and hearing people say, well, we understaffed. It's just not enough for us today. I'm so sorry I'm late. It gets old. But your legislators are the one who determine whether or not these facilities get away with only putting 3 nurses in a place, 1 respiratory therapist in the entire building. Those things exist. There's a lot of reasons why people aren't staying there. It's a lot of reasons. I think it's a pretty building.
So
Yeah.
So what we're hearing is a narrative. We're hearing a narrative of what has been happening for more than a year, for really going on about 7-8 years, just with Cedar Hill. I went back and looked at some of the meetings that I've had at the Health Alliance Network that go back to really 2016, 2017, talking about the need for health care east of the river. So as we talk about some solutions, let me share with you what is happening and then some ideas. So first of all, I mentioned earlier that we are looking into whether or not GW through UHS and MFA broke the contract with the city, did not fulfill their obligation. Whether or not the creation of a new MFA, a new organization, also breaks the contract that they had with the city. There are instances of potential mistreatment of patients at Cedar Hill, which may include malpractice. We are going to be launching a website where people from east of the river can file and lodge their complaints. We will be doing that shortly. And not just patients, but also nurses and also doctors that can file their complaints about their experiences at Cedar Hill and their experiences with UHS and MFA. We're also looking into whether or not that means or will constitute a class action. We're also looking into whether or not the district and the council needs to step up and call for a new contract. Back in 2017, I presented 2 members of the council and to the Health Alliance Network at least 6 different companies that have stronger community benefits for hospital systems than UHS ever had. And why didn't the district shop the need to go for another hospital operator around the country? It seems as though they didn't talk to anybody but UHS. Why is that? We're also looking at, additionally, so we talked about the possibility of people lodging their complaints. We talked about the potential of abuse at the hospital. We also talked about physicians and others lodging their complaints. There's also negotiations going on with the community doctors, and I'll let Dr. Corder and Dr. Chapman talk about that. But in addition to that, there has to be more that has to be done. We have to really look into what the city did, look into what UHS did, and whether or not that passes the muster. Do we need new legislation? Do we need a new hospital operator? What does Ward 7 and Ward 8 actually need? And it's not UHS, given the history of UHS and given what has happened with this hospital. So we're also open, and it's an open discussion if anyone out there, any one of you have ideas as to what could be done. The last thing I would say is that they have to open up this board. Right now, there are 2 unfilled seats on the board. but they've only allotted for, was it 4 community doctors to be on the board, a board of 32. So where is the community voice on the board in an equitable way? There are only 4, and then there are still 2 seats that are unfilled by the mayor at this late date. So, Dr. Cordes, share with us what's happening in terms of the talks with community doctors.
Thank you. I want to also say, before I talk about that, when I was chief of staff, we got full accreditation. JCO came, and we scored highest in most of the hospitals in D.C. Also, through COVID, our system, and we met every week and then twice a week with the pharmacists, our system was the best for COVID tracking and giving vaccines, that even Vince Gray came. Kamala Harris came to our hospital to get her COVID, she and Doug. So we have good track, and that was even as they cut the funds. So we as community doctors are interested, but we have had many doctors, at least 8, have said they put in their credentialing, and for some whatever reason, they didn't get a call back. They've been sitting, just like the respiratory therapist said, applications and applications and applications. Then there's no conversation of any coverage of malpractice. There's no conversation of rent being at least 3 months. You know, when you have to restart a practice, it takes a few weeks and months to build it back up. So there's no allowance for that. So we've been told we're asking. So there's several things that as we are talking, and we still are there at the table, that we need to make sure that we're clear of the other benefits from the other doctors versus what they can do and help the community doctors, because we will bring the patients. All they have to, once we're there, that hospital will benefit greatly. But we want to make sure, as you said, even the leadership board. So on the actual board, there's 2 seats, but on the Med Exec, the MEC committee, there are 32, and they said, we're going to give you 4. But that's the voting board, and that's the department heads that the UHS system appoints. And those chair of the departments determine who's going to be part of their departments at Cedar Hill. But they're not at Cedar Hill. They're over in Foggy Bottom, in upper Northwest. And I'm like, how are you going to run the hospital and you're not there? So one of the proposals and solutions would be, let's have the department heads here, be it the community doctors, but let's be here, because then the oversight for the allied health, for the NPs and PAs, et cetera, in the docs, you know, that we all there and have commitment right there on site on the grounds of St. Elizabeth. So we have to get it right. And again, some doctors, they're coming on board, but they're like frightened, because if something's happening and they're the doctor in charge, they don't even have the malpractice coverage. So it's a little bit scary and dicey. We're still going to be there talking, but we want to have a community person, maybe a physician and a community person, so that the transparency, that the communication and the needs are met.
So we're at a crisis situation, and we really need to look at what does the community want? What did the community expect? Number one, you should be able to have a baby in your community and not have to travel across town, which means you should be able to have prenatal care in the community. That's a high-cost item. A premature baby costs, $90,000 the first year. A term baby costs $3,000. So if you could at least establish prenatal care at that hospital with whatever it takes, whether it's free rent for pediatricians, OBGYNs for 5 years, the hospital needs the volume. So you can start there. Then you can look at other resources like gastroenterology, in and out procedures, low risk items. You could bring in ophthalmologists, cataracts, and in and out surgery, urologists. But you have to look at it from a financial standpoint and a trust standpoint. But the initial costs or overhead, the rent and the malpractice is insignificant compared to what they bring in terms of reputation and patient volume. So I would really think that someone needs to sit down and set a business model. The other thing is we met with the interim CEO and Barbara Banks-Wiggins is there representing IPRO Clarent, and they are the quality control agents that actually report to CMS, Medicare and Medicaid, for not only DC, but Maryland, Virginia, West Virginia, Delaware, and Pennsylvania. So the idea is to bring innovations, and one of the innovations that we proposed is to develop a tracking system, an advanced tracking system, so that when somebody goes to the emergency room, that we get their demographic information and then connect them to a primary care in the community, and that primary care person would reciprocally use the hospital. So it would be initially a closed network with the understanding that these are physicians that are going to use the facility, but they're also going to get some benefits by reestablishing that. But you're going to have to use that network of physicians to build a PR face. I'm not talking about ads on TV. I'm talking about a real trusting, supportive PR connection. And then you need to connect with the churches in the community for those social determinants of health. We have homeless people in our community that are being scattered. Instead of scattering the homeless, we could have used the old UMC as a triage site, as housing. We could have used the, on New York Avenue, the what is it, the Salvation Army building, to bring homeless folks in. We have 3 medical schools here. If I was a medical student and you brought a homeless person in, you're gonna find a lot of stuff. When I was at DC General in one night as a student, I saw things that I never saw again. So, but you're providing a service, and that service is also lowering the cost of unnecessary repeat services that run the Medicaid cost up. So the money is there. It's building a business model that goes after the least, the last, and the lost. Those are the 5 to 10% of patients spend 50% of the healthcare dollars. So if you go after that 5 to 10% of patients, that's where the savings is.
So there are people here that are running for office. There are people here who are staff persons of those that are in office. There are people here who are staff members for those that are in office. I'm not going to point them out, but this is also part of the strategy. The ones that are running for office but never held office before, this needs to be in their platform. It needs to be discussed. There are those that are running for mayor. I've been in contact with some of those that are running for mayor. It needs to be in their platform. The health care of black people east of the river. Number 2, the staff members of council members who may be here. The council members need to send a letter to the Office of the Attorney General for DC, requesting that the Office of the Attorney General, and you all can write this down, render a legal opinion as to whether or not the contract has been broken. The DC Attorney General needs to say and weigh in. But see, I as a civilian cannot make that request. But a council member can make the request of the OAG to render a legal opinion as to whether or not the contract has been broken. Those that are running for office of mayor need to demand that an opinion be rendered as to whether or not we need a reset, a restart. While that is happening, we are pursuing other possible legal means to remedy what has happened at Cedar Hill so that the community can be whole. Everyone who is here who has the wherewithal to be a proponent, the wherewithal to be an advocate, needs to go back into your community and be an advocate. You've heard from nurses, you've heard from staffing experts, you've heard from doctors, you've heard from chief of staff of doctors. You heard me read the news reports that have happened over the course of a year. I didn't even go back beyond last year. But there's even more news reports going all the way back to 2017. The director of healthcare finance is quoted as saying back in 2017 that the only way Cedar Hill will be successful is when white people move into Ward 8 and black people move out. He's quoted, a Channel 7 news reporter quoted him saying that. What did he know and when did he know it about MFA? What did he know and when did he know that there was a real possibility that this deal would fail Ward 7 and Ward 8 residents? When did he know? And the council member needs to bring him in and ask him, when did he know? Did he think that it was going to fail? And why weren't the people notified? This is serious business. And we can't treat it as anything such. So for my part, I will be asking this question of candidates and ask, what are they going to do? I heard from two mayoral candidates this today. They know that it's a serious issue. And we're going to find out just how much they're going to fight on behalf of black residents in Ward 7 and Ward 8, especially if they're trying to be mayor. So this is part of the strategy. We're going to address it through the community doctors. We're going to address it through the nurses and the relationship that this entity has to have with black nurses. And let me just say lastly, there was a report that was and Dr. Chapman shared this report with me, that was published in the Harvard Review. It was a study. The study said that black patients get better health care from black doctors. Why is that? Not because the black doctors had more expertise or were better than white doctors. That had nothing to do with it. It was because black patients established a cultural connection with black doctors and black nurses. And because of that, they took care of their health better. They listened to what their doctors were telling them to do to take care of their health. So we know that we need black doctors and black nurses. So why didn't UHS and MFA make that happen? Why didn't Wayne Turnage, who I am calling right now the Robert Kennedy of DC Health, why didn't he make that happen? Why didn't the mayor make that happen? So we want to leave you and ask, number one, if you have any ideas for solutions, but not to hold you any longer if you don't. You can always come to any one of us if you have ideas. I have meetings the first Monday of every month. They're online, the Health Alliance Network, and I will be in contact with you if you did sign the sign-in sheet. Okay?
And I wanted to also add, we now have a group that we have formed, the physicians, because we singularly are concerned what can happen to one doctor after another in terms of being, told to leave. So we are led by Kim Dickens, and our group is Pioneer Health, so that we can come in mass, we can come and address the needs of the community with the specialties and the primary care. So that's part of our solution. So we got together due to Kim Dickens having a phone call, and then she called me, and then the rest is history. So we're that committed, and we're formalizing.
Just a caveat to what Ambrose said. Black physicians from Howard, Meharry, and Morehouse are more likely to locate in our communities, and we locate in our communities because that's who we are. It's not that we're not good. We want to lift our community up, and the only way we can do that is to be in the community.
Well, I'll just say this. I'm really excited about us getting some solutions together. I am excited to work with anyone who is willing to put forth an effort to close these gaps. I am excited about all of you showing up because this is very heartwarming to me. I wasn't sure how many folks were going to show up. This is a very good crowd, so thank you guys for coming too. But like I said, I'm excited about us forming some partnerships because we've been asking for that as business. I'm not the only business owner that's been asking for that, but we've been asking for partnerships, so I'm excited about doing that, and I'm excited about continuing to service you guys.
I just want to say again, thank you everyone for coming out and supporting, and I'm as an expert in nursing and as a PhD medical scientist, I would tell you two things. Know your rights, and also, if you have any issues with the providers you have now, you have a right to ask and request an alternative providers. Demand the partnerships with Cedar Hill to reach out to community health doctors such as myself, many of the other panelists, create those partnerships, MOUs, those agreements, because it's the law. They are not supposed to cut us out of your care, and they are responsible for the quality of that care by making sure that we have alternative measures, alternative holistic health care for the whole person. It is their job to do that, and that starts with you speaking up and knowing your rights. I'm Dr. K. If you want to follow me on social media, please do so. My firm and my clinic, Well Connect, that's WELLKONNECT, that's Well Connect. We are contracted by the federal government. Our job is to ensure that your quality of care remains in your hands.
My research and program fellow is in the back. If you could stand, Michaela, don't. She was a little incognito, but that's all right. And thank you all for coming. If you have any ideas, you can share them with me. You can give your name and email address or number to Michaela. And thank you, of course, to Resurrection Baptist Church. Thank you, Brother Nate, for your work. Last call on the sign-up sheet. Mr. Goodweather has the sign-up sheet, so we will have some solutions. Yes. Oh, sign-up sheet? Come on to the mic. Come to the mic.
Hey, Doc.
How you doing, doctor?
Yeah, Brownie, I know you.
I'm Dr. Brown,
To the mic.
and I've been hearing everything you're saying. Okay, let me just give you a quick summary. My father created his surgical practice in 1960. I took it over in 2001. And I've been practicing. And practicing here in this community, Ward 7 and 8. Now I'm a Ward 4 baby. I grew up in Ward 4, DC original, went to Boston University, engineering, Georgetown University. I didn't go to Howard,
We love you.
but I went to Howard for surgery. I got trained there. University of Chicago, University of Illinois. I've been on staff at all those places. When this hospital closed, April 15th, I put in my application. You know, I haven't heard from them yet. Okay. Now, I'm qualified in my training from all those universities, mostly white universities, that I could go to Georgetown, go to Hospital Center, go to GW. I didn't want to. He practiced here. He created his practice at Hadley, when it was originally Hadley. He was chief of staff, chief of surgery there. And he had an office at Providence. I took that over. And I had an office at United Medical Center for 25 years to April 15th, 2025. We talked about the hyperbaric chambers. I ran those. I ran the wound center there for the last 7 years before they closed in April. I told them, we have in Ward 7 and 8, 48% of all wounds in the entire city. And I was seeing a bunch of them. So there was no reason that we couldn't make money there. It's just that the powers that be didn't want to put money into the place, and they bled it dry. I ran hyperbaric, and I tell you, when they kept saying that we weren't making money, I was sitting up here like looking at my calculations and saying, wait a minute, you're not collecting? I'm making a good living. So how the hell are you not doing it? So it's always been a management issue. And if you don't, as customers, remember, as a patient, you are a customer. If you go to McDonald's or you go to the Hilton or whatever, you check in, you pay, you expect a certain level because you are a customer, paying customer. That's what the hospital is. But what the hospital seems to also forget is the physicians are customers. Where do patients go? They go to where their physicians are. All right? So right now, I'm on a year-long sabbatical because I haven't heard from GW. 1, and 2, I'm not going to sign. Well, I had originally talked to somebody there. They said I had to join MFA. Hell no, I'm not joining MFA. I have my own malpractice. I will do what I want to do. I'm not going to have somebody who's going to try to tell me how to practice and all that when they don't have my credentials, okay? There are a lot of black physicians, and I don't think I've seen you in a long time, Dr. Chapman. I think it's been a couple of decades that we can come together and get this place working. But here's your solution. And the first part of your solution you got to look at is you got to go back to the original document justifying the new hospital. You really need to read that, because when I read through some of the quotes and consultant things, whatever, I already saw that this was going to become a failure down the line, okay? It was way back then. As the hospital was closing, I think Dr. Corder knows, I was making us think about certain things, because it's like, wait a minute, we aren't being included in this process. You know, when did I find out that we could apply for privileges? It was like March. That problem should have been started way before they opened. But let's get back to the original document. They opened the hospital with no office, okay? No office building. That's the first thing they should have built, all right? So when they closed the office building at United UMC, a lot of us doctors were scrambling to see where could we go. There was a couple places that right down the street, office building, but then the build out would be ridiculous. To set up my kind of practice is $150,000. I'm not committing $150,000 if I don't know what my privileges are going to be over there, and most importantly, am I going to be able to practice without somebody overlooking me trying to say, you don't know what you're doing. I already know y'all don't know what you're doing. You know, I got 4 fellowships on my name, so don't come telling me certain things. You know, it's like I did 2 dual fellowships, so it's like I know what the heck I'm doing. All right, but I don't want to go to GW because I don't want to deal with the politics. It's the politics of color. I already know that. I don't want to go. I refuse to go to hospital center because it's the politics of color. And Georgetown said wanted me to come there, and I'm like, I don't care. I might be a grad. I'm not coming. All right. I want to practice here in Ward 7 and 8. That's where my practice has always been. That's where it will be when I restart. But until Cedar Hill gets fixed or slightly fixed, and that was one of the reasons why when it opened, well, when they did the closure, I was like, this is going to be a mess. I don't want to use the term, but CF, if you can figure it out, I knew it was going to happen because you can't close a hospital of one that is functioning and open up a new place that has no idea how your systems are going to work. And I did not want to put my reputation on that line. And so I'm willing to go there because I'm always planning to, and going back to Howard. But if we don't start from the very beginning and look at that document, you're not going to find the solutions. Secondly, you're not going to find the solutions unless you put the council to the fire to them. Because now they've spent $434 million of our money. You know, I pay a whole lot of taxes. And you have I don't know what you call it, a green elephant, gray elephant, whatever the heck we call it, a white elephant that's just sitting there looking pretty, you know. And if you don't have people of color in, if you don't have people of color in the administration, so that's the other thing is that we have to demand not only representation on it, but proportional representation. 32 members on a board and you only have 4 physicians, that's stupid, okay? If you don't have the chiefs of the departments practicing and functioning there, it doesn't work. We tried that model when I was in California at one of the hospitals I was at where they wanted to do that. And I was like, no, we're not doing that. And so even though the powers that be still went ahead with it, they learned their lesson the hard way. 18 months later, they were like, no, we got to put people in there. So the only way that you're going to get this done is as customers, as people who live in this ward, you need to call your council people, not only your ward council members, but all of them, including the chairman, and blaze their phone. That's the only way it's going to work. That's all I got to say.
Any other thoughts or comments? And if there are, just step up to the mic. Otherwise, we're going to close out. And if you could make an offer to the church before you leave for use of this building in this sanctuary, that would be really, really nice of you. And you could probably give the offering on your way out. I think there is there a plate that you can have on the way out? Yes. So please make an offering on your way out for the church. And thank you all for coming, and stay tuned.